he got his papers done. Yeah. I hope he did. I don't talk to him that much. I let my wife do most of that talking. I just listen into the conversation he's having with my wife. Did you guys ever do this with your mom? Like, she'll sit there and she'll be on the phone with my son for like 2 hours. He calls like once every few weeks, you know. And she'll be on the phone with him for like 2 hours and won't be talking. I'm like, are you still on the phone with Mitchell? Yeah, he's doing something on his computer. He just wants to have her on the phone while he's doing something. And I'm like, what are you doing? I would not put up with that. I'd just be like, click. I don't have time for this kind of crap. My wife just loves I just know he's there and I can hear him breathing, you know. I'm like, God. Glad I'm not a woman sometimes. All right. Spinal region. We'll move through this fairly quickly. Slow me down if you need anything. These are our objectives. We're going to talk about a quick review of anatomy of the spinal region, everything within the vertebrae, the spinal cord, the little roots that come out of it, the spinal nerves, and the coverings of the spinal cord, the meninges, which you have meninges covering all your central nervous system, so brainstem, spinal cord, and cerebrum. Here's what it looks like from the front and the side. From the front, you see there's a little bit of a bulge up on the top and bottom. There's a cervical enlargement and a lumbar enlargement just because there's a greater number of neurons that come into there from a sensory standpoint and go out from a motor standpoint to the muscles of your arms, upper extremities and lower extremities. A little less in the trunk, so it's a little narrower there. You can see something to appreciate as you're looking at exiting of the nerve roots between the vertebral levels, between the bony structures here, is in the cervical spine, these nerve roots, they exit above their respective vertebral level or vertebral body. Then when you get to C7, then you have a C8, which comes out below C7, and there is no C8 vertebrae. And so what happens there is then now all of the rest of the nerve roots come out below their vertebral level. So we'll draw it out here on a little bit easier to see diagram. So if this was C5, let's just say, and this was C6, and so in the cervical vertebrae, the nerve root comes out above its vertebral level. So this nerve root that would come out here from this intervertebral foramen here is going to be C6. And so if you're reading, you know, an MRI or X-ray report or something like that that talks about foraminal stenosis at the C5 and C6 level, or a disc herniation between C5 and C6, you're most likely going to see C6 symptoms if they have any symptoms. A radiculopathy, they're going to have maybe sensory or motor dysfunction in the C6 spinal nerve. If it's between C5 and C6, it's going to be that lower vertebral level that's associated with the nerve root, so C6 in this case. But when you get into the thoracic spine, you know, T1, T2, let's say this is the spinal nerve root coming out of here, comes out above its vertebral level, so this is T2. Sorry, below. Sorry. T1. And so if you have a disc herniation, a foraminal stenosis between T1 and T2, then it's the T1 nerve root that's most likely to be impacted there, and that goes all the way down through the rest of your lumbar spine, thoracic and lumbar spine. So just the clinical significance there is just a good one to appreciate. Of course, when you evaluate your patient, you'll pick up their symptoms, and that should point you in the right direction as far as myotomal, dermatonal dysfunction that is associated with a specific nerve root. We've already talked about the ventral and dorsal roots that come, you know, out of the spinal cord. The ventral roots primarily are going to be efferent motor information. There is a little exception to that with some autonomic function and sensation of the autonomics that come in through the ventral roots, but don't worry about that right now. The dorsal roots that come in the back of the spinal cord, that brings in your sensory information, afferent information. Remember the proprioceptive fibers, axons, they come in that medial division of that dorsal root, where the pain and temperature come in that lateral division of the dorsal root. So this entire structure here, this is your dorsal root, coming in here. And we can divide it into a medial group here, so more medial, and then a more lateral group here. And the medial group of fibers, those 1As and A betas and 2s, are all coming in there because they're going to go into the dorsal columns. They're going to come in a little more medially because they're going to immediately go up those dorsal columns, those fibers, those axons coming in the dorsal root. And then the more lateral group of fibers here, more lateral, is going to be coming in, and they're going to immediately go in and synapse in the dorsal horn, and that's your pain and temperature fibers, right? Because then they're going to synapse, and then they're going to cross over in the anterior white commissure and cross over the other side at this point. We have segments of the spinal cord which are defined by the groups of rootlets that come out of the spinal cord that combine to contribute to the dorsal and ventral roots, which make up your spinal nerves. So you'll see here, there's these little rootlets coming out, and then this is what defines the segment, where those rootlets begin and end coming out. Your dorsal and ventral rootlets define the segment of the spinal cord. And it's not a hard line like this. It's more of a blurred line, when you're going from one segment to the next. So the spinal nerves that come off, once the roots come together, right? The dorsal and ventral roots come together to form the spinal nerve. And then they have these primary rami that come off. So the spinal nerve comes together, and then very quickly it branches into a dorsal primary ramus and a ventral primary ramus that we've showed you pictures, and we'll review it again. Carry all motor sensory axons in a single spinal segment. And if it's between T1 and L2, or L1, L2, it's also going to carry some sympathetic autonomic fibers as well. Okay. The spinal nerves split into that ventral and dorsal primary rami once they get through the intervertebral foramen. The dorsal primary rami innervates paravertebral muscles and the posterior vertebrae and overlying skin, so the back part of your body. The ventral rami goes to the skeletal muscles and cutaneous areas of limbs and anterior and lateral trunk. We've also talked about the gray and white ramus that's associated with the sympathetic chain ganglia from T1 to L2. This is a picture you're familiar with. I've showed you before. That, we start with, let's go back to yellow maybe. Start with our ventral and dorsal roots. They come together here. Here's the dorsal and ventral roots. Here's our dorsal root ganglion. And then here's the intervertebral foramen right here. Here's the foramen where it comes out. As soon as it comes out, this is the spinal nerve right here. That little segment right there before it immediately branches into a dorsal primary ramus that goes to the back part of your body here, and the ventral primary ramus here. Okay. And then we have, if this is a thoracic segment, which this is because there's a little lateral horn there, and we also have the sympathetic chain ganglia. So that's another reason we know we're in the thoracic area here. And this is the white ramus, and then the gray ramus here. So remember, it comes in this way, then comes back out that way. So that's that. Moving into the internal structures of the spinal cord now, we're going to go through some kind of cross sections here. We have white matter. The white matter is kind of grossly divided into two separate areas. There's what we call propriospinal axons. These are axons that begin and end within the spinal cord. They're actually really close to the gray matter, and they help pass information between segments of the spinal cord. This is especially important for reflexes that involve multi-segmental levels, like the crossed extension reflex, where you flex one leg and extend the opposite leg, and you have hip flexors working and extensors on the other side. That takes communication between multiple levels, so there's a way to send signals within the spinal cord via these propriospinal axons, and I'll show you where those lie here in the next slide. And then we have the tracts, the motor and sensory tracts, which we spend a whole lot of time talking about, all those motor and sensory tracts that run in the white matter of the spinal cord, a little bit more lateral and around the edges of the spinal cord. Okay? And there typically is usually some type of somatotopic arrangement of certain major tracts. So especially the anterolateral system and the cortical spinal tract for motor have a nice somatotopic layout or arrangement with them. We have the gray matter, which is in the deep inside, which is where the cell bodies are lying. You have the ventral horn, which is motor, dorsal horn, which is sensory. Then we have the lateral horn, also known as the intermedial lateral cell column, T1 to L2. That's where your preganglionic sympathetic cell bodies lie. We also have a little lateral horn in the S2 to S4 segments where your preganglionic parasympathetic cell bodies lie. The gray matter can be divided into these 10 phylogenetically distinct kind of cell types, these 10 layers called rhexid laminas. Then within the rhexid laminas, there's some also distinct regions like nuclei, like Clark's nucleus and so forth, that are also in there that may, or substantia gelatinosa, that may encompass multiple rhexid laminas, okay, that have functionally distinct things they do, but they cross over a couple different areas of rhexis lamina. This is a really nice picture. I like this a lot because it's nice and color coded and easy to see. So everything in light blue on there is a sensory pathway, okay? And you'll see the sensory pathways are more towards the edges, a lot in the back there. Everything in red is a motor pathway. So this just gives you appreciation. How does it all fit in there? Well, that's kind of how it all fits in there. And then the purple, that is propriospinal axons. They're really close to the gray matter, so there's some axons that run up and down and communicate different segments of the spinal cord via those propriospinal axons. And this particular region right here, this is called Lasauer's tract, or the posterolateral tract of Lasauer's. That is where some of your pain and temperature information comes in. Remember I mentioned that some of it immediately synapses in the dorsal horn, but a lot of it will go up and down 1 or 2 segments before it makes its synapse. And that's where it happens. It's going up and down, and that it's one of the propriospinal pathways. Not proprioception. It's called propriospinal, but it doesn't have anything to do with proprioception. It's just where these communication between segments in the spinal cord occurs around that gray matter there, just on the edges of that gray matter, allow that communication to go up and down there. Okay. This is just showing you some of the somatotopic arrangement that we have here in the spinal cord. So we know, like, for example, the dorsal columns back here is somatotopically arranged so that this more medial is lower body, right? And then this is a cervical, actually this is not a cervical segment. This must be a high thoracic segment above T6 because we've got upper body in here as well. So remember this is the dorsal column for upper extremity. And it really doesn't get going until you get up above, you know, T6 or a little higher, this is probably closer to like a T1, T2 segment here if we've got upper body in there, because we've still got these little lateral horns here that's showing some autonomic function. But then, so that's upper and lower extremity somatotopically arranged here. And then this is the cortical spinal tract. This is your lateral cortical spinal tract here. And it's somatotopically arranged so that from kind of medial to lateral, going medial to lateral, you start with upper trunk, or upper limb, I'm sorry, upper extremity, then trunk, and then lower body, more lateral, okay? That's how they're layered in there as they're coming down, the motor tract coming down there, the cortical spinal tract. Then we have a rubrospinal that's in here that's just particularly for upper extremity flexion. That isn't really somatotopically arranged. It's just, those are just going to your upper extremity. But then this right here, this is your anterolateral system. We're going to just call it your spinothalamic tract for now. Fast pain, but slow pain's in there too. But it also is somatotopically arranged from medial to lateral, starting with upper extremity more medial, then trunk, and then lower extremity more lateral. Okay. This will have some implications when we start talking about spinal cord injuries, and when we start talking about specifically a central cord lesion that might affect maybe upper extremity disproportionate to lower extremity when you have more the medial part of those pathways impacted by a central cord lesion. So this is just showing you some of the anatomy here. Again, the rootlets that define the segment. Here's your meninges here, down here. This is the pia, the real small cellular layer here that's connected right to the nervous system tissue, axons. And then we have the arachnoid, Arachnoid is the next layer, right, with the little end feet, and there is cerebrospinal fluid running in that space between the arachnoid layer and the pia, and then the real tough dura mater out farther. This is just showing you a cross-section that's stained. So the stain is typically specific to myelin. So the darker the structure, that's white matter. So it's like a reverse negative. And this is the same thing you're going to see with when we get to the brainstem sections. The stain they use stains and binds to the myelin or the oligodendrocytes in this case, because it's a central nervous system structure. So this is only demonstrating one dorsal column back here, the fasciculus gracilis. So we know we're at least probably below T6 with here. We don't see any evidence of fasciculus cuneatus starting here, and we have really small dorsal and even ventral horns, right? So that means we're probably like mid-thoracic somewhere, because all we have to do is get a little bit of sensor information from this little strip of skin around our trunk, and only have to supply a few intercostal muscles, a few maybe parts of our abs and paraspinal muscles. So there's not a lot of cells in there. So we have pretty small gray matter in there. We do have a little lateral horn on each side, so we're definitely where we have some sympathetic outflow going on there. This is just showing you cross sections through cervical. Here's that thoracic, kind of mid-thoracic spine. This is T10, actually lower thoracic spine. Lumbar, and then sacral. Sacral gets harder to define some of those ventral and dorsal horns there. So you just appreciate the size. So in the cervical spine, there's a little bit more of a medial to lateral kind of spread there. It's a little wider, medial to lateral, than it is anterior to posterior. In the thoracic spine, it's very circular in nature, and it stays pretty circular in the lumbar spine. It starts to flare out and have a little more variation in the sacral area. So the Rex's laminas, which are those laminar layers in the gray matter of the spinal cord that we've mentioned a few times, these are 10 histologically distinct regions in the lamina. So the cells are a little different in each of these regions, and that's how they define them. I've starred the ones that you need to know, pay most attention to. Lamina 1, which is called the marginal layer, and lamina 2, lamina 2 is mainly what makes up the substantia gelatinosa. That's where you process information about noxious stimuli, pain, and some temperature there as well, but mainly pain there. So lamina 1 and mainly lamina 2, a little bit of lamina 1, and then also a little bit of lamina 5 as well also contributes to the substantia gelatinosa. I'm trying to remember now. No, yeah, it does. Lamina 5 is down there, but I don't have it starred. That's noxious stimulation, but that's more from the viscera. So it does process pain information, but it's more from your visceral areas, where lamina 1 and 2 are from your sensory systems of your musculoskeletal and skin regions, okay, from your limbs and surface of your body. Lamina 3 and 4, also known as the nucleus proprius, those have some integration and get some communication, get some collaterals going to them to deliver some proprioceptive information to those laminas 3 and 4 together, also known as the nucleus proprius. Lamina 5 is some noxious stimulation information from the viscera. Number 6 also does some proprioception processing. Lamina 7 includes the nucleus dorsalis, Clark's nucleus. T1 to L2 for unconscious proprioception, right, with your spinocerebellar pathways it's associated with. And then that's your posterior spinocerebellar pathway, where some of that information is coming from your lower body, goes up the dorsal columns until it gets up to Clark's nucleus at T1 to L2 and communicates there, and then ascends up. Lamina number 8 that's connections with the contralateral cord, and you'll see where it's in the middle of the gray matter, so there's allows these connections between the contralateral side of the cord. Lamina number 9, cell bodies, is where your lower motor neurons lie, and the cell bodies of those, or anterior horn cells, are in lamina number 9 for the biggest part of them. Number 10 also includes neurons which cross to the other side of the spinal cord. And then we also have the intermediolateral horn, which is just those areas in T1 to L2 and S2 to S4 associated with autonomic function with sympathetic and parasympathetic cells. So here is the rexid lamina structure that we've talked about. So here's lamina 10, which is communication with the other side of the cord. So there is some, this is where you can get communication between each side of the cord as far as cell bodies communicating the gray matter here. We have crossing over of some pathways in this anterior white commissure just in front of that lamina 10, but that's white matter. We're just talking gray matter right now. So within the gray matter, there is some ability to have some cross communication between the gray matter on each side of the spinal cord, again, for integration of these complex reflexes that require, using both sides of your body, whether it be like a stepping reflex, some like a central pattern generator, which you start walking in communication, or some like the cross extension reflexes and so forth. Here's lamina number 9. You can see it's spread out here to various regions. This is where most of your anterior horn cells are located, and you can see it has multiple regions here, which are associated with some of those medial and lateral and anterior motor neuron pools that are kind of represent our body there. Flexors, extensors, distal, proximal kind of regions they go to. Lamina 1 and 2 here, which really is your substantia gelatinosa. When you take those two together, the substance of those together. And then on this side, you have some of these distinct nuclear kind of regions here that may cross, over multiple rexid laminas and aren't defined within a specific rexid lamina. The meninges, the covering, the pia is that pia mater, that little couple cell layer thick pia mater. Couple of things that the pia mater is unique is that it is what creates what's called the denticular or denticulate ligaments. They're not really ligaments, but that's what they're called, the denticular or denticulate ligaments. A little extension of pia mater extends off the side of your spinal cord and anchors it at the different vertebral body levels and anchors your spinal cord side to side. And then at the very tip of your spinal cord is the filum terminale, a little piece of pia mater that extends off the tip of your spinal cord and anchors it to the sacrum. Okay. Then the next layer is the arachnoid and then the dura. So this is showing you here, they've reflected back the dura, and then up here you're seeing some arachnoid, and they've peeled back the arachnoid here now. They've cut kind of the arachnoid and peeled it off. And now deep to the arachnoid, you can see these little guys extending off here, these little wings coming off to the side here. They extend and they kind of pierce out. They pierce out of the dura and then go over to attach to the vertebral body, the vertebral kind of arch area, body area in the spinal column. Okay, and those are the denticulate ligaments right there. So that was a pretty quick overview of some more of the anatomy of the spinal cord, internal and external anatomy of the spinal cord. Now we're going to go forward with some basic function of the spinal cord. What does it do? A lot, and we can use that to our advantage in physical therapy by taking advantage of some of these more complex reflexes. It's more than just a conduit. It's just not to transmit information to and from locations. There's processing that occurs for certain types of activities. The spinal cord is more important than your cerebrum. So, when I learned neuro, it was all about this hierarchical structure that the cerebrum is more important than the brainstem, but the brainstem is more important than the spinal cord, and then one kind of, it's this top-down thing where one controls the other. It may in certain circumstances, but other times, certain basic types of movements, the spinal cord is the most important structure for a certain movement, especially if it's more reflexive in nature or more primitive in nature. Okay? There's a lot of exchange of information with other spinal cord segments, the brain and the periphery that goes on. A lot of integration that goes on at the spinal cord level. We have a lot of interneurons in the spinal cord, just like you have in the cerebrum. We always have to remember we have more interneurons in our spinal cord and our cerebrum than any of the other neurons we've talked about to this point. We've always talked about these, afferent and efferent neurons associated with motor, sensory, and autonomic. They're really important, but they're actually the minority. There's actually more interneurons that allow integration and communication and processing of these functions. So, afferent and efferent information. So you've got sensory information coming into your spinal cord, and you've got motor information going down all the time, and they're all converging in your spinal cord on interneurons. And then they change, the interneurons will influence how those two pieces of information come in and will help modulate what sensation eventually gets up to your conscious awareness of your systems, but also the motor output, okay? So the spinal circuitry really allows for modulation of sensory input, okay? So it modulates the sensation that comes in, filters it, defines it, helps decide what's going to get up to the spinal cord, also up to the brain and brainstem, but also we have descending pathways that help modulate pain down a little bit if we need to, or we can ramp it up if we feel like we need to be very protective of our bodies. We can have pain being ramped up a little bit. We have coordination of movement patterns. Basic movement patterns can be coordinated at the spinal cord level. And then a lot of autonomic regulation is reflexive in nature, especially the sympathetic nervous system, okay? Can regulate a lot of its own circulation and temperature and so forth at a very reflexive level without a whole lot of control from the hypothalamus and those kind of things. So talking about some of the basic spinal cord control of motor output, so the motor reflexes in the spinal cord. Most spinal reflexes are not like the deep tendon reflex. That's the simplest reflex. The monosynaptic deep tendon reflex is as basic as it gets. Most of them involve complex inner networks of interneurons, okay? We've mentioned the good old withdrawal reflex, the classic withdrawal reflex. The characteristic depends on the type and location of the stimulus as well as the body position. So even though we talk about it as, boom, this is your typical withdrawal reflex, or you step on a nail and withdraw your foot, but your body knows if I'm in a standing position, I better make sure the other leg has to go into extension and support myself. Plus I have to counterbalance that with an equilibrium reaction in my abs and my head to keep everything lined up so I don't fall over. So that's all happening via those propriospinal axons communicating between segments. Also, one side of your spinal cord communicating with the other side, and really involves these multiple muscle groups at different levels of the spinal cord, okay? Because that stuff has to happen before it even gets to your conscious level, or you're on the ground, so this all has to happen at the spinal cord level. So that's all this is showing you here. This is just showing you, here's pain on one bottom of your foot coming in. You see this is going up multiple levels here via that intermediolateral cell column. Remember we talked about that's that propriospinal axons, that purple area back there that allows you to transmit to multiple levels, because you have to go to multiple levels, because you're activating, you're activating quads on one side, but then you're having to cross over to stimulate other neurons on the other side of your body here. Okay. We also have what are known as kind of basic inhibitory circuits. So we have circuits that activate muscles and create motor activity, but we also have inhibitory circuits, because you got to always have that balance, right? We have reciprocal inhibition, which is mediated by the spinal cord. So that's when you're activating the agonist on on your limb, and the antagonist is inhibited. That's happening with the spinal cord level. Decreases activity in the antagonist when the agonist is active. Okay. Input to reciprocal inhibition neurons can come from descending motor tracts, or from the 1A cutaneous and joint afferents telling you that your limb is bending one direction, so don't inhibit that. It can be modified when co-contraction is needed. Your body knows if you are in a closed chain position and I'm doing, like a push-up or something like that, that I may need some co-contraction between my biceps and triceps. So if I'm doing a push-up on my way up, I'm not going to totally inhibit my bicep because I still need some co-contraction to stabilize around the joint because these both have attachments around the shoulder, that kind of stuff. So, and that's because you notice you have weight bearing through the bottom of your hand, through your joints, through your shoulder joint that are coming into that spinal cord area to say, hey, let's modify the typical reciprocal inhibition when then if you're doing it more open chain where you really are looking for a fast movement and making sure that one muscle doesn't interfere with movement of the other. Recurrent inhibition, this is where you have inhibition of the agonist muscle and all of its synergist muscles. It uses a recurrent collateral and a Renshaw cell to exert its influence. This is a little bit counterintuitive. It's used, this term recurrent inhibition is mainly used for when you're doing fine motor stuff, where you're really trying to isolate certain muscles and muscle fibers to work and have everything else not do its job. So you're trying to isolate movement, not get too much motor activity when you're doing especially fine skilled types of movements. It narrows the focus of the motor signal so that you're only using the muscles, fibers, and muscles that you need while inhibiting all the rest of them around it, including its synergists. Okay, it's kind of like also acts as a governor to prevent muscle damage from muscle tetany. So there is in addition to that fine motor stuff, if you overactivate a muscle where it senses it might be damaged, this recurrent inhibition is kind of like a safety switch on the muscle. Let's shut down because you're trying to work me too hard. You're doing too big of a whatever bench press or something like that, and I'm going to shut you down. It's not because of the Golgi tendon organ, although the Golgi tendon organ feedback plays a role in that, but some of this has also played this process of recurrent inhibition in these Renshaw cells. So I'll show you here, I think a picture in a second here. So this is kind of a classic, this is what's happening with reciprocal inhibition. So if you're activating, you're doing some knee extension, your muscle spindle is shortening. It's going back here into the spinal cord level. Now this would have to go up or down some levels. And in case if you want to inhibit your hamstrings, you got to go down a few levels, right? You got to go down your quads like L4, you know, L2 through L4. Your hamstrings are going to be that S1 to S2, so it's going to go down. They're just showing it all at one level for simplicity's sake, but it's going to go down, you know, a level, and then it's going to have a inhibitory interneuron that's going to go and tell your hamstring to turn off or turn down. So this is recurrent inhibition. So here's showing you some motor fibers here, and so you're firing motor fibers in, say, your thenar eminence there, your whatever flexors of your metacarpal there, or adductors and so forth, trying to do some fine motor skill. And you're trying to get it so you just get certain ones activating because you're trying to do something like, I don't know, tie a knot or tie something like that, button the shirt. And you don't want all of these things just to fire grossly. So when you send that signal down to help refine that, you actually have some little, here's this recurrent branch, recurrent collateral branch of an alpha motor neuron that goes back to these little inhibitory interneurons called Renshaw cells. And these Renshaw cells, if you're trying to fine-tune something, they may send collaterals back, and those branches may go to certain muscles, even to the same muscle they're embedded in, and say, that's too strong of a, you're contracting that too strongly, or I only want this portion of the muscle to contract now. And that helps to refine that so it down-regulates certain muscles or muscle fibers around that so it can fine-tune that signal a little bit. Okay, and that's happening right at the spinal cord level. And then that's more at that fine-tuning level. Then there's like mass inhibition effect. If you get too much activity and too much, you know, where it's damaging, you're not talking about these little muscles of the thumb, but like in your quads or something, you're doing a big motion where there's a sense, or where you're going to damage the muscle. You can fire a bunch of these Renshaw cells all at one time, reach a certain threshold that they all get kicked on, and turns off all the muscles that are involved in that motion. Okay. Which, if you're doing a bench press and you don't have a spotter, that's a bad thing, right? Because eventually they're just going to go and it's going to come down on your chest. That's why you always want to have a spotter with you when you're really maxing out, because if you get this mass inhibition all of a sudden because you're going to damage your own joints or muscles, then you want to make sure somebody's going to catch that weight for you. This is continuing on in inhibitory circuits. Non-reciprocal inhibition is when you get inhibition of the agonist, its synergist, and the antagonist muscles. This is where you have received afferent. It's a combination of the afferent information coming in about how much stress your system is under, plus the motor signal coming down, and it may shape overall motor output on a larger scale, where you may have to, this is where like you're trying to do that putt, you know, and you're like really having to quiet your nervous system down to do this in a smooth way without having any overactivity of any muscles. And so this non-reciprocal inhibition is where you just quiet the whole motor system down, including agonist, antagonist, synergist. This is where, like, you know, using mindfulness and breathing can help influence this non-reciprocal inhibition so that you're shaping overall motor output on a larger scale. Like, hey, this thing I'm about to do doesn't require this level of intensity or motor output. I need to down-regulate everything because this is a more subtle movement. This is something that's required more smoothness out of my movement. So I'm going to down-regulate by inhibiting everything a little bit. There's a negative stretch reflex, which is where you have rapid shortening of muscle spindles. Actually inhibits the muscle it's embedded in. People will use this in physical therapy for like a technique called strain counterstrain. I don't know if you've ever heard of that. There's called strain counterstrain. But what they do is they use the concept of the negative stretch reflex. So let's say somebody's got a really like a trigger point or spasm in their cervical muscles, you know, and their scalenes or something. What they'll do is they'll kind of find this trigger point and they'll put their finger on that, and then they'll take you and they'll put your head in a position to shorten that muscle maximally. And they'll usually keep some pressure on that muscle because they'll actually use some kind of proprioceptive gating mechanisms that also occur when you put pressure on something. You get some proprioception to kind of cover the pain. But then they'll shorten that muscle as far as they can shorten it, and then that kind of resets or creates this negative stretch reflex where you shorten the muscle spindle so much that even your gamma motor neurons have a hard time keeping the muscle spindle sensitivity by shortening the muscle spindle, and so that it kind of resets it. So then what you do is you take them extremely slowly while you're maintaining some pressure on that trigger point to kind of trick it, and you take them back into the mid position, and then that supposedly is resetting that. And then you can do some isometrics and so forth in that position to turn the muscle back on without reactivating the sensitivity of the muscle spindle by doing that. So that's using this negative stretch reflex. I don't know that it works. There's not a lot of research. That's theoretically what they think they're doing, this resetting. Any type of movement or pressure to a muscle will tend to confuse the muscle and make it feel better for a period of time. When you just do any kind of movement and combined with pressure and those kind of things was going to activate a lot of proprioceptive signals. So that's really I think what they're doing is not necessarily, they're not resetting the muscle spindle per se. They're just creating enough afferents coming in that it masks some of the pain, combined with some gentle movement. Slow movement feels good for most people versus fast movement. So this is a very slow process that they take you through when they're doing this. So. This is just showing you this kind of non-reciprocal inhibition where, you know, if you notice you're getting tons of strain in a certain limb or something like that, some of that information gets here. Some goes up the dorsal columns to tell your conscious system, hey, there's lots of strain going on. But some of those actually go into there is some delivering of some of that information into the dorsal horn. And some of those areas of rexid laminas we talked about for proprioceptive, 90% of it goes up the dorsal columns for conscious awareness. Some of it to the spinal cerebellar pathways, but some of it gets transmitted up here. And then some of it might fall on these inhibitory interneurons that are non-reciprocal. That means that they just go to inhibit everything. So here you're inhibiting biceps, brachialis, tricep. You just get down regulation of the whole limb if it's if it's concerned about being injured or something like that. Or you're just trying to refined movement where you don't want to, you want to shut everything down so the limb is just not working so hard. Over time, when you first start learning a new movement, you tend to overuse your muscles. You tend to use too much motor output when you're first learning a new skill. But via this process, over time, you refine it, and you can actually then say, hey, I really don't need that much motor activity to do this skill effectively. And this is one of the ways you can shape that movement, as your spinal cord learns that, hey, I can use non-reciprocal inhibition. I can just turn that limb down 20%. Than I used to. As I'm getting better at this skill, I can still achieve the same result with less motor output, because our bodies are always thinking efficiency. How can I expend the least amount of effort and energy to gain the outcome? This is just one method of doing it. There's tons of methods for our body to do that. This is just one at the spinal cord level. Some other complex we've mentioned before is postural and locomotive reflexes. So we have reflexes for keeping our bodies upright against gravity, these basic postural reflexes, and that's also involved with when you're destabilized and being able to make accommodations in your trunk and head position. Then we have stepping pattern generators that just generate the basic stepping patterns of our body. Stepping pattern generators use what we call reverberating and oscillating circuits. Reverberating circuits are circuits where once you get them started, they tend to keep going until you tell them to shut off, okay? And then oscillating circuits are when you oscillate from like flexion to extension, or from one side of the spinal cord to the other. So they tend to stay going once you kick them on, and then they also tend to be oscillating in that they tend to create flexion extension reciprocally, or left and right stepping reciprocally. That's the oscillating nature of these circuits too. So this is an example of how a reverberating circuit might be set up. So you've got this cell stimulates this cell, which happens to have a collateral that goes back to the previous cell, and the same thing here. So once you stimulate one, they're kind of self-stimulatory. They keep going and self-stimulate until you send an inhibitory signal back to that first one to say shut down. And that's kind of what your brain does. Your cerebrum tells your spinal cord to turn on and turn off. I want to start walking now. And that's, you get the reverberating. So once you're walking, you're not thinking about it. Now, then you have to say, stop walking now. And your brain stops that reverberating circuit from occurring, okay? Things like positive supporting reactions and righting reactions, like especially like little kids when they're young, you guys learn some of the different milestones. When you place them on their feet, they tend to try to extend and push up with their toes. That's a positive supporting reaction. We still have some of that, but we're not dominated by it. In kids, it's too strong where their toes point down and so forth. As an adult, you want to be able, you don't want your toes pointing down when you're standing up, but you do get a little bit of a positive supporting reaction. When you sense pressure on the bottom of your feet, your body extends into that a little bit to keep yourself upright within reason. You don't want to go full extension, but you want to have some balance there. And then if you get destabilized and you start to lean to one side, the lateral side bending of my trunk and the tilt of my head to keep myself in line, which is using some vestibular information plus proprioceptive information coming from my foot about what's happening to keep that, that's a righting reaction, okay, to keep myself lined up so I don't fall over and keep my head oriented to vertical so I can keep seeing my environment level. And a fair amount of that, it's not all at the spinal cord level. Some of that occurs in the brainstem, but a fair amount of it at spinal cord level. And then we've mentioned autonomic reflexes that occur. Many functions of the autonomic nervous system are controlled at the spinal cord level. So basic changes in vascular tone, okay? Remember the sympathetic nervous system tends to maintain a little bit of vasoconstriction, especially in our peripheral and surface tissues. In this case, skin, and in muscle, although then there's different mechanisms for allowing muscle to vasodilate during exercise, but that basic changes in vascular tone. Localized sweating, so like if you were to take and put a hair dryer right on your skin here, you could get some localized sweating just over that region, but that would be because of a spinal cord reflex with your sympathetic nervous system that would allow you to start having that sweating versus sweating over your whole body, which requires the whole body core temperature to rise. This would be just over a certain like dermatonal area or skin area that you would get that localized sweating. Basic GI reflexes. Okay, so your GI system works pretty well all by itself. It doesn't need, and that's why, I mean, people with spinal cord injuries still have their GI system still works. They can still, process food, have bowel movements and so forth. Bowel and bladder, they don't work quite as well because you obviously can't control when that happens, but they still happen. You can still, you know, have bowel movements and excrete urine and so forth, but it's just no longer under your control when that happens. So, although you can train your bowel and bladder, especially your bowels, to get very regular with even with a spinal cord injury. So they go through this process of bowel training where you basically have to stimulate the bowels at a very regimented time frame each day, and then over time your GI system learns that and it says, oh, this is now the time that I'm going to have a bowel movement on most days once you get it in that regular schedule. And then same thing with the bladder to an extent. Our bladder is much more dependent on how much you're drinking at any given movement or at any given moment. So they learn though how to regulate how much they intake as far as fluids and knowing about their windows, exactly how long they have and when they're going to start having a full bladder and getting better and better at controlling that and so forth. Yeah.
Is that something that like a pelvic floor PT would do?
It's actually for spinal cord injury. A lot of times nurses do that bowel and bladder, but I think people that have that training definitely they should play a role in that. Pelvic floor type things can help play a role in some of that, but typically pelvic floor people are doing it more. People that don't have spinal cord injuries, but I think there's a role for them in that area. So. There's a thing we've talked about called the mass reflex. This is where large portions of the cord are activated due to a noxious stimuli. A mass reflex is what is playing a role in this thing we call autonomic dysreflexia. Okay, it's common in head injury and spinal cord injury. So if you have damage to if you have a head injury that's enough that you lose some conscious awareness of your body and what is perceived as really threatening stimulus or not, or you damage the hypothalamus with a head injury, or you damage the spinal cord, especially if the spinal cord is damaged above the level of T6. What happens is now you've basically taken out control from higher centers. You no longer have your cortical thinking regulation. You can consciously regulate some of your autonomic nervous system through slow and deep breathing or recognizing whether some stimulus is truly just mildly irritating or life-threatening, and also your hypothalamus can help control some of this too and gives you a little more refinement of your autonomic nervous system control. But once you lose that control, now the sympathetic nervous system, mainly, we still have some parasympathetics in our sacral area, but we've got all of our sympathetic nervous system no longer has input from higher centers. And so if you get any little noxious stimulus, any little bit of pressure on your skin, a full bladder, something like that, your body will perceive it as something life-threatening. And your sympathetic nervous system just turns on, okay? And it goes boom, fight or flight. So you get all your vascular tone, like you get constriction of all your peripheral vessels. Your heart rate shoots up through the roof, and now your blood pressure goes up and all that. And so, but they don't have a chance. They can't. Their brain and their hypothalamus can't tell the sympathetic nervous system, hey, chill. This is not a life-threatening emergency here. You don't need to go crazy. There's no way to inhibit it. Okay, so that's this autonomic dysreflexic response. Let us take a break right there. Any questions before we take a break? Good, mostly review so far. All right, so we are still on some control of function at the spinal cord level itself. Talked about some motor control. Now we're talking about, and also about control of the autonomic nervous system, so those autonomic nervous system reflexes. Now let's talk a little bit about pelvic organ function. So we're talking about kind of bowel and bladder sexual function here. So at the sacral level, S2 to S4, and the lumbar nerve roots that come at the sympathetic fibers coming out of T11 to L2. So we've got parasympathetics coming from S2 to S4 and sympathetics from the T11 to L2 region. Those are the ones that help supply those four centers for bladder, bowel, and sexual function. Okay, so we have reflexive and voluntary bowel and bladder function. The spinal cord is most important for the reflexive part of bowel and bladder function. Okay, so the sympathetic nervous system, what it does, it tends to promote relaxation of the bladder wall and contraction of the internal sphincter of the bladder. So sympathetic nervous system is for retaining urine, okay? So it allows your bladder wall to be relaxed, allows urine to collect, and also maintains the contraction of the internal sphincter, which keeps it from leaking out, okay? The parasympathetic system, you use that to contract the bladder and relax the internal sphincter, and then you use your conscious control to relax the external sphincter so that you can urinate, okay? The frontal lobes are used for the voluntary control. You have striated muscles in your external sphincter that you have voluntary control over to contract or relax your external sphincter, versus the internal sphincter is controlled by the sympathetic and parasympathetic, counterbalanced by those. For sexual function, for either erection of the penis or engorgement of the clitoris, it's a combination of parasympathetic and sympathetic control that allows for optimal functioning here. Parasympathetic plays a bigger role in the reflex part of that process, where the sympathetic has some control from higher centers that has some connections with cortical centers for the psychogenic control. So people that have spinal cord injury that is above the levels of T11 to L2, a male anyway, and female, they can have engorgement of their clitoris, but a male can have a reflexogenic erection, but it won't be quite as effective, or as if you've also got the psychological or psychogenic component via some of the other pathways. Okay, some of the so it just depends on if the spinal cord injury is below that T11 to L2 region, if you lose the psychogenic part of it because you lose the sympathetic fibers of this, if you have a low spinal cord injury, but you still may have the reflexogenic part of it because you still have the S2 to S4 segment still functioning. Okay, versus if it's higher up, it's harder because then you lose both psychogenic and reflexive. You still have the reflexive. You still have if you haven't damaged the S2 to S4 segments, you have the reflexive, ability to have an erection with external stimuli. Okay, it's when you damage way down on those S2 to S4 segments, which would be a very low spinal cord injury, then that's when you would have trouble with the both reflexive part of it and the psychogenic part of it. Okay. For the process of ejaculation or vaginal lubrication, the sympathetic fibers, particularly exiting at L1, L2, play a role in this, as well as parasympathetic fibers. So again, there's this combination. Both of those need to be working to have optimal levels of this. And there's some somatic systems involved with some of the contractions that occur during ejaculation and so forth that is superimposed on the sympathetic control. So you can have varying levels of function depending on where you have a spinal cord injury, where you have damage in the spinal cord. Okay. This is just showing you where some of these parasympathetic and sympathetic fibers are exiting and the different areas they're innervating of the bladder. This would be for control of the bladder, the bladder wall. You see the internal sphincter and the external sphincter there at the bottom. And you can see the innervation that counterbalances the innervation between those two, sympathetic and parasympathetics, that either contract the bladder, relax the bladder, contract the internal sphincter, or relax the internal sphincter. And we'll get into lesions of the spinal cord, and then we'll kind of talk about, again, the effects on pelvic organ function when we get into lesions here and try to make sure you feel a little more comfortable with that. Anytime you have a lesion to a spinal cord, you're going to have both segmental and vertical tract problems. Okay? The segmental problems is the damage that you're occurring at that segment of the spinal cord that affect that specific segmental level. So if you have damage at like C5, if you've got a spinal cord injury at C5, you're going to damage anterior horn cells, nerve roots that are coming off right at that C5 level, right? If you've damaged, that's where the damage is. But that's the segmental damage. So you're going to impact actual anterior horn cells, dorsal roots, ventral roots, whatever, at that level. Okay, that could cause like flaccid paralysis at C5 in just that one C5 area, okay? Or cause dermatonal loss of all modalities of sensation in that C5 root, okay, or area. But then you're going to block descending signals that are going to trying to get past that, and ascending signals that are trying to get past that level where it was damaged. Those are the vertical tract dysfunctions. So you're going to get motor dysfunction below the level of the lesion, and you're going to get sensory dysfunction below the level of the lesion because it's going to have a harder time getting past that lesion. So you're going to have, this is going to disrupt information getting below the lesion or coming up from below the lesion, but then you're going to have loss of function directly related to the lesion at that segment. Does that make sense? So you typically have some combination dysfunction. But when the segmental loss of dysfunction is so insignificant compared to the vertical loss of everything below the level of lesion, we don't really talk about that. But, you know, so if somebody had a C5 or C6 damage, normally you would expect with a vertical tract, upper motor, this is an upper motor neuron problem, they'd have hyperactive reflexes. They would below the level of the lesion, like at the knee and the ankle, but their bicep might be hypoactive because you actually damaged anterior horn cells at C5 and C6. Their tricep would be hyperactive because that's a little bit lower. That's from the vertical tract being dysfunction. But if you actually wiped out C5 and C6 and damaged those anterior horn cells and also that stretch reflex coming in there, you might actually have hypoactive reflex at the biceps, okay, because of that. So spinal region syndrome. So there's types of spinal cord syndromes that most patients fit into. It's usually never perfect, but you do occasionally see people that fit really nicely into one of these spinal cord syndromes or mostly into one of these spinal cord syndromes, okay? So the first one is the anterior spinal cord syndrome. This affects the ascending spinothalamic tract and descending motor tracts and anterior horn cells at the level of the injury, okay? Typically, though, it's interesting is vibration and conscious proprioception are spared. So these people feel like they can feel everything, although they really don't feel pain as much, but they feel like they can feel their body, know where it is in space, so they feel like they have sensation, but pain and temperature may be impacted, okay? This is most common with a hyperflexion injury of the C-spine. So this would be like, here's a diving incident where the person's getting hyperflexed with their spine, okay? Or somebody is at a car accident and their head goes forward really strongly, or tackling incident or something like that where their head is hyperflexed will tend to cause these central cord lesions. So what happens here, here's a case where you get a hyperflexion injury which often results in a burst fracture, okay, of a vertebral body because you're basically flexing vertebral bodies against each other, and usually one takes the brunt of the force. There's one that gets compromised, the burst fracture happens, and some of those fragments get pushed back into the spinal cord, okay? And when you're pushing a spinal cord in this, you have this spinal canal, and you're pushing it back against the lamina back here, and when you're squeezing something, the area of the tissue that gets the most pressure is what's in the center, right? And so when you're pushing two things together, the area that experiences the most stress is what's getting pushed in the middle. So it tends that if you're going to have damage, that tends to happen in the center of the spinal cord, in that tissue that's most central, because it's getting pressure from both sides. So the central area of your spinal cord tends to get more damage in this case, okay? The other thing it tends to do, this is showing, yeah, so this is showing, this is an anterior spinal cord syndrome, not a central cord syndrome. I'm sorry, I was telling you guys central cord syndrome. This can lead to central cord syndrome, but we're talking anterior spinal cord syndrome here, so sorry, I was starting to get a little confused and go down the wrong track there. So this affects the front part of the spinal cord. So in this case, what this vertebral fracture has done, it can cause a central cord lesion in some cases, but it also can impact the anterior spinal artery. If it doesn't affect the anterior spinal artery, it can lead to central cord syndrome, but in this case, we're showing it as if it affected the anterior spinal artery, which you'll see here. The anterior spinal artery is right here, and here's that fracture and splintering here. and it can cut into, put pressure on that anterior spinal artery. And then that anterior spinal artery, when we talk about blood supply, you'll learn that it supplies the anterior 2/3 of your spinal cord. So what you're going to have is, first of all, you're going to have at the actual segment, so here's anterior horn cells coming out here. Depending on where this lesion is, you will see flaccid paralysis of whatever that level of spinal cord injury is at just those segments. So like if that's C5 or C6, you might see a very flaccid paralysis of the biceps, where the bicep is very atrophied and has no reflexes and so forth. That can occur because of those anterior horn cells being damaged. But then we have vertical tract problems. This is the spinothalamic tract. So all pain and temperature trying to get up past that lesion from below the level of the lesion is going to be impacted on both sides of the body. So you're going to have complete loss of pain and temperature below. This is the corticospinal tract here. So this is motor pathways coming down both sides of the spinal cord. You have complete paralysis below the level of the lesion, spastic paralysis. Now there might be that period of spinal shock right after you have the injury for the first couple hours to first few weeks. They may have lower reflexes and really flaccid paralysis, but eventually they're going to have hyperactive reflexes, okay? And that's because it's an upper motor neuron problem here. You're damaging the descending white matter tracts here that go down on both sides. So complete paralysis below the level of the lesion. Spastic in nature, upper motor neuron. At the level of the lesion, they may have a few lower motor neuron deficits right at the level of the lesion because of the anterior horn cells here. Loss of pain and temperature, both sides below the level of the lesion. But look, dorsal columns are totally spared. So these people feel proprioception, they know where their body is in space, they think as if they feel like normal. However, they're still at risk for things like pressure sores and things like that because they don't have pain and temperature. So they may sit on their bottom in one spot too long. You still need to teach them to shift their weight and de-weight their body and so forth, and make sure that they're monitoring their skin and so forth because they don't have the pain and temperature coming up, to give them awareness of that. So they're still at high risk for pressure ulcers. This is anterior spinal cord syndrome. So central cord syndrome usually occurs at cervical levels, is the most common to get a central cord injury. The cervical spine has a lot more movement than your lumbar, and it's more common. Spinal cord injuries are more common in the cervical spine in general. Okay, but certainly central cord lesions are much more common at the spinal cord level than they are at the lumbar thoracic levels. You just have a lot more hypermobility in your cervical spine. You've got a big head on a smaller neck for most of us, and so it's vulnerable to this, deceleration. There's leverage on your neck with your head being, and versus in your trunk. It's a little bit harder to hurt your back because you've got more stuff in trunk and musculature around it. There's also a thing called syringomyelia, which is a very rare disorder where you actually get this opening in the middle of your spinal cord. It's a degeneration in the middle of your spinal cord, and it becomes this fluid-filled, they call it a syrinx, S-Y-R-N-X, something like that, syrinx, S-Y-R-I-N-X, syrinx. And myelo, M-Y-E, is spinal cord. That's the same. That's synonymous with spinal cord. Anytime it's not myo, not a muscle, it's myelo means spinal cord. Okay, so syringomyelia is this syrinx, this fluid-filled cavity that develops. It's a degeneration of this tissue in the middle of your spinal cord. They don't know what causes it. It's idiopathic and can lead to degeneration of the center part of your spinal cord, and it tends to happen in the cervical region. If you have a very small lesion, it might just cause segmental loss of pain and temperature only, and we'll show you how this works. A larger lesion, as the lesion expands out from the center, it can cause impairment of more upper extremity motor function, okay, and some upper extremity pain and temperature even below the segment. So we'll show you how this works. So this is actually showing a hyperextension injury and some pinching, but the central part of the spinal cord is a little more vulnerable. Anytime you twist, extend, flex it too much, the center is a little more vulnerable because everything pushes into the center, you know, and tweaks it. So, or any bleeding into the center of the spinal cord. You could have a tumor in the center of your spinal cord that could also do this, can cause this process. This is just this is an osteophyte. Like, so some of us, especially as you get older, you get these osteophytes, these little bony little hooks and protrusions from the edges of the end plates of your vertebral bodies. And so an older adult gets in a motor vehicle accident and their head gets whiplashed and hyperextended or hyperflexed. Those osteophytes can dig in and poke in and pinch the spinal cord and cause that damage more towards the center part of the spinal cord. So here is a very small central cord lesion. You'll notice that it's only impacting this very central region of the spinal cord. And what it's impacting here is, in particular, that what you care about is this anterior white commissure. And so everything else is getting by this lesion, right? So cortical spinal tract, spinothalamic tract, dorsal columns, for the most part, 99% is getting past this lesion. So this person is not experiencing any paralysis, because these are lateral cortical spinal tract is fine. Even all the medial activating systems in here are fine too. So they're not experiencing any paralysis. They're not experiencing any proprioceptive loss, because that's all making it past the lesion. They're not experiencing any pain and temperature loss below or above the lesion, because it's all making it pass from both sides here. The only thing they're experiencing is pain and temperature loss bilaterally just at the level of the lesion. So in this case, this is a C4, C5 injury. So this lesion is extending through the two segments, C4 and C5. Never is a lesion a thin little slice where we're going to show it. The lesions usually extend through more than one segment. They usually extend up and down a little bit in the segment. So all this person has is loss of pain and temperature just in the C4, C5 dermatomes. Because what's happening here is just at that level of the lesion, everything coming in, pain and temperature coming in from here, remember, it's going to go and it's going to try to cross over in the anterior white commissure, but it's going to get stopped there. But it's only going to happen at C4 and C5. Everything that comes in below C4 and C5, or anything that comes in above C4 and C5, it's not going to be impacted by the lesion. Because if it comes in below, it's going to cross over their side and then go up the spinothalamic tract, or it's going to come in this side and it's going to cross over, and it's going to make it past that lesion. So the only thing this person's going to have with this very small central cord lesion is just loss of pain and temperature at that segmental region. So this is a good example of a purely segmental deficits associated with this, because you're just not impacting any of the vertical tracts with a very small spinal cord, central spinal cord lesion. You're just not big enough to impact these vertical tracts. Okay? However, if this lesion starts to extend out, so if the lesion is a larger central cord lesion, now you'll notice we're starting to impact some of these vertical tracts. And even parts of, the dorsal columns here, okay? So this person, most of the dorsal columns are still okay, so they'll still feel like they have decent proprioception. You might have to really look for the deficits and find which parts of the dorsal columns here of their limbs are affected here in just those certain little regions. They may be able to tell you, this feels a little more numb to me, this area of my arms on each side or my legs on each side feels a little more numb. But most part, they're going to feel pretty good about their dorsal columns. And you have a decent representation of both upper and lower body here, right? They're kind of equally being impacted. However, when you start moving into, this is the cortical spinal tract, and this is a cervical spinal cord segment, as you can tell by it's more wider, medial to lateral. It's got big anterior horns and ventral horns. And here's the cortical spinal tract, and this most medial right here, this is upper limb function, right? Remember we showed you somatotopic arrangement? That's upper body. So this person, all the area of the upper body below this level, so let's say this is a C6, C7, C8, T1, are going to be affected. And so they could have weakness in their upper body in all those areas below the level of the injury, but nothing in the legs. Their legs are fine because, look, legs didn't get impacted. So they're walking around, yet they have very little arm function. And so it's a very kind of unique presentation. Like they come walking into you and you go to shake their hand and they have very little function in the upper body, but you're walking around. That's a classic central cord lesion, okay? They would also have wherever this, and then also here, pain and temperature. This is the spinal thalamic tract. That most medial part of the spinal thalamic tract, that's also upper extremity. So they're going to have a disproportionate loss of upper extremity pain and temperature loss, okay? Below the level of the lesion, legs are going to be okay, but upper extremity pain and temperature may be impacted. But also right at the segment, we're going to have loss of bilateral pain and temperature because of the segmental where they're trying to come in and cross the other side. So if this is a C5 and 6, we'll also have that kind of total loss of pain and temperature at C5, 6. But even below that, because if it's a big enough lesion, you're impacting the rest of the upper body's pain and temperature. But proprioception will be mostly okay. They'll still be able to feel where their arms are in space for the most part. They might have a few numb areas on their arms. Okay? So that's a central cord lesion. The farther it expands out, the more it starts to affect. If this syrinx keeps growing, like if this was a syrinx, that fluid-filled cavity, what happens is they start out with having, initially they just have like, hey, I just got a little, I can't feel temperature. I notice when I'm in the sun, I don't feel it on my shoulders anymore. And that's just that loss at the segmental level. Then all of a sudden their arms start getting weak. And they also get spastic, you know, potentially, depending on how much those anterior horn cells are damaged too. Because sometimes the anterior horn cells, if it's involving the reflex levels, will then mask this upper, it'll mask the descending. And then eventually their legs start to get a little spastic, you know, because it starts pushing out. And eventually start impacting, you know, that lesion keeps growing out. It might push into the trunk and lower body region. And then their legs started getting weak and spastic too. But they comes on later. It starts with the upper body, then moves to the lower body. If it's a progressive lesion like a syrinx, if it's an injury, it stays pretty stable. So that's, I just showed on that. I was going to draw it on this, but we just showed you pretty well how that occurs here. Brown-Sequard syndrome. This one you already know pretty well. We've talked about Brown-Sequard. This is half the spinal cord being damaged. Gunshot, knife, tumor, trauma, something that impacts just one half of the spinal cord. You're going to have segmental loss at the actual level where the injury is. So you're going to have loss of lower motor neurons and all sensation coming into that one side of your spinal cord at that level, okay? Whatever that might be, T11, C12, C5. Then below the level of the lesion, you're going to have ipsilateral loss of motor. When we're talking about ipsilateral and contralateral, we're talking reference to where the lesion is. So the same side of a lesion, you're going to have loss of motor function, proprioception, discriminative touch, and contralateral loss of pain and temperature. So that's what this is showing you. Here's a hemisection of the spinal cord. This is a T10. So at the segmental level, you're going to have loss of all motor function because you've damaged all the anterior horn cells here, segmental loss, which would be hard to pick up on a T10 lesion because it's only, T10 is only going to a few, you know, muscles of your intercostals and abdominals and that kind of stuff. And you also have loss of all modalities of sensation just at that level. So because you've impacted all the dorsal roots coming in at that level, right? So you've lost pain and temperature, proprioception, all ipsilateral to the lesion. They just can't even get in there, but only at that segment. That's the segmental dysfunction associated with the Brown-Sequard syndrome. Then we have the vertical tract dysfunction, which is going to be impacting cortical spinal tract. So everything coming down is going to get blocked there. So everything below, you're going to have ipsilateral, same side loss of motor function on that same side. Okay, it's getting blocked there. Then you're going to have everything below that lesion of proprioception that's trying to come up the dorsal column here is going to get blocked at that level. And remember, it hasn't crossed yet. So you're going to get loss, you're going to get ipsilateral loss of proprioception on the same side because they can't get past the lesion. But you're going to get contralateral loss of pain and temperature. Pain and temperature on the contralateral side, because remember, all that information came in below the spinal cord and crossed over and is now trying to come up on the spinal thalamic tract. It's getting blocked here. But everything that comes from the other side, pain and temperature wise, crosses over and misses the lesion. Okay? So that's why you have the contralateral loss of pain and temperature. And then ipsilateral and everything else. And I was just going to draw that on that, but you guys are already aware of that. Then another type of syndrome, and it's not really a spinal cord injury, although they call it a spinal cord injury. It's really damage not to the spinal cord, but to the roots as they come off the spinal cord, right at the tip of the spinal cord. Because remember, our spinal cord ends, between L1 and L2. The disc, the intervertebral disc between L1 and L2 is where our spinal cord ends. So if you actually have a spinal injury below L1 and L2, L5, L5, S1, L4, whatever it is, you can damage the nerve roots without damaging the spinal cord. Okay, and typically, anytime you just damage the nerve roots as they're exiting off the bottom of the spinal cord, that's called a cauda equina syndrome. Okay, so that's damage here to the cauda equina and the nerve roots coming off to the sacral or lumbar nerve roots. This is going to cause sensory impairment and flaccid paralysis of lower limbs, bowel, and bladder, because this is a lower motor neuron problem. You also are going to have sensory deficits potentially, because remember, there's still sensory nerves in those, and there's also parasympathetics in there as well, in the S2 to S4 region. And so they will have this flaccid paralysis. They're not going to have any spasticity, no reflexes, potentially depending on which of the spinal nerve roots. This is somebody who jumps out of a plane, the parachute opens a little late, they land on their butt, and they just get this big compression fracture of the sacrum, lower levels, or somebody in a violent car accident where they have a seatbelt on but no lap belt, and they get a fracture dislocation like between S1 and L5, and their whole vertebral body shifts an inch forward and just shreds and just shears their spinal nerve roots. The nerve roots coming off of that. That's going to cause this cauda equina syndrome. And it's actually almost more challenging to have this flaccid paralysis in a lot of ways than a spastic paralysis, because what happens is you also have flaccid paralysis of your bowel and bladder. So it's kind of like versus your bowel and bladder, just like your muscles in your arms and legs, can be either spastic paralysis or flaccid paralysis. If you damage up in the spinal cord, you get a spastic bladder and bowel, where the tone is a little high in them, so they tend to stay contracted, so you don't just have urine and feces leaking out of your body because they're still slightly over-contracted. So it's harder to get it out because you got to work at it, you got to do stimulation, you got to do some tricks to get it to come out, or catheterize yourself or something like that. But if you have this lower motor neuron, flaccid paralysis or bowel bladder, you can't even control the external sphincter at all. There's no tone in the muscle, there's no tone in that, and it just kind of leaks out all the time. So you always have to wear, they actually have like catheters for your anus you can put on there to kind of like a bag that you can tape into place there to keep it as it leaks out. And then you have to wear constantly a catheter. You have to have an internal catheter to keep always as the urine is produced. So it can be a challenge. And the legs, when you have very flaccid legs, they're easier to get, kind of like they fall off your wheelchair a little easier. They are harder to manage. They get more atrophied, so they're bony prominences. They can injure themselves more easily with that. So cauda equina syndrome is definitely a tough injury for a lot of people. There is a posterior column lesion. This is where you can get just select damage to just the posterior columns, which is just going to lead to proprioceptive losses, but you'll still have normal pain and temperature. From everywhere below the level of the lesion would have loss of, at the lesion and below the level of the lesion will have loss of proprioception, conscious proprioception. You still have unconscious proprioception. The spinal cerebellar pathways are okay, but conscious proprioception is impacted. The patient will feel numb. They feel like they can't feel their limbs. But if you touch them with a cold thing or a hot thing or stimulate with pain, they'll feel pain and temperature. But they'll feel numb, or like their arm or leg feels like wood or dead to them, yet they'll still feel some pain. So these people actually have less chance of having damage to their skin because they feel, I better shift my weight because I'm starting to get pain in certain, like my bottom and those kind of things. Tabes dorsalis, which is associated with syphilis, which in our country we don't see a lot of that, but long-term standing syphilis can cause degeneration of the posterior columns. You're most likely to see it with MS, is where you're probably going to see somebody who's got select lesions in the posterior part of the spinal cord, and MS might have lack of proprioception because of that. AIDS can lead to some degeneration of the posterior columns. This is just showing you, normally you'd want this to all be this darker color, but you see this is a tabes dorsalis where you've got degeneration and loss of myelin that should be staining dark in those posterior columns of the spinal cord there. Effects of spinal region lesions on pelvic organ dysfunction, so kind of revisiting pelvic organ dysfunction and specifically where you have different lesions of the spinal cord. If you have a lesion in the cauda equina, so you're damaging those S2 to S4 segments as they exit out, those parasympathetic fibers that are coming out and damaging the actual neurons, the nerves, not the spinal cord, you're going to tend to have a flaccid bladder and you have no reflexive bowel emptying, okay? These people might have the rare ability to have a reflex erection, but it's only occasionally that they have that reflexibility because you basically damage the reflex loop, right? But you don't always wipe out all the S2 to S4. You might have some functions, so you might get some reflexive ability to have erections, but it's like damaging the reflexes in your knee or something like that. If you damage the actual lower motor neuron, essentially going to your pelvic organs, you're going to have the inability to have these reflex kind of things. Questionable psychogenic erection because you still have maybe, if you damage S2 to S4, but you still have some of the nerve roots from T11 to L1 coming down there, that's for controlling the psychogenic erection, but you need both to have a really good erection to have normal sexual function, okay? And so it's questionable. Sometimes you can still have that, and they do have some ability to ejaculate because the sympathetic neurons may still be okay if they only damage those S2 to S4 segments. If they still have some of those T11 to L1, area nerve roots that are intact, they'll be okay with some of that. If it's a woman, if you've just damaged the S2 to S4 segments down there, they still have sensation and function above that. And so they'll feel uterine contractions during birth, and they can assist with those because they still have innervation to their core muscles and trunk muscles and abdominal region because that's above S2 to S4. So we're talking just down really low at that S2 to S4 segments with this type of function. Once you have a lesion above the sacral segments, and now you are into the spinal cord, okay, we're down, and not in the cauda equina, and not wiping out the actual anterior horn cells in the S2 to S4 region. We're above that. We're up in the spinal cord area, more specifically. You're going to get more of a hypertonic, hyperreflexive bladder. So their bladder will be a little bit shrunken up, and they won't be able to store as much urine. Sometimes that then backs up into the kidneys and causes increased pressure in the kidneys. So people with spinal cord injuries are at high risk for having kidney problems over time and can damage their kidneys. And then when they do when they catheterize themselves or you try to get the urine out, normally when you have a normal contraction of your bladder, there's a combination of both reflexive and some somatic contraction of your abdominal areas that make sure you get it all out. So you have very little residual urine left in your bladder. When you catheterize yourself or use pressure and not effective or as efficient means and you don't have the normal contraction of the bladder, you get most of it out, but you usually have what's called a residual volume. And that residual volume, just if it stays in there, it just makes you prone to having bladder infections and so forth. and then also getting that back up into the kidneys and so forth. So you're looking for people to try to get rid of that residual volume, and they'll often test that. They'll come in and do an ultrasound of the bladder right after somebody's catheterized themselves to see how effective they're getting, what's their residual volume afterwards. Okay. Eventually that bladder, because it's always contracted, it loses some elasticity, so they lose some capacity for storage too. People that have lesions above the sacral segments, 70 to 93% of them are still able to get reflexogenic erections, because if it's above, well, especially if it's above the T11 to L1 regions. So if you have the damage up here in the cervical spine or thoracic spine, the reflex loop is still intact. If you stimulate the person externally, that sensory information gets to the spinal cord and can stimulate a reflex erection. But you lose some of the psychogenic parts of that, because you can't send signals from your your cortex down to those areas if the lesion's above that T11 to L2 region. Okay. However, they have difficulty with ejaculation. Only 4% are able to ejaculate. Okay, with lesions above those sacral segments. Lesions, if the lesion is above T10 for a female, they have difficulty sensing and assisting in uterine contractions. Okay, so if it's above T10, they will have difficulty. And if it's above T10, they also then have those decreased psychogenic erections. Okay, if it's below T10, they actually still might be able to send that signal to that T11, L1 segment to help stimulate for the psychogenic erections. So that's just showing you this. Here's just lesions to the cauda equina, to the actual axons and lower motor neurons, so to speak, that go to the pelvic organs. This is going to cause that flaccid, distended bladder and lack of control of the external and internal sphincters. If the lesion is above the S2 to S4 segments in the spinal cord, it's going to cause this contracted, spastic type bladder situation, because you still have the reflex loop here. And so you have hyperactive bladder reflexes. Essentially, it causes that spastic. Just like you have spastic muscles that have a little increased tone in an upper motor neuron disorder, this is the equivalent of an upper motor neuron disorder for your bladder. Okay. Let's talk about traumatic spinal cord injury briefly. Motor vehicle accidents, the most common cause of traumatic spinal cord injury. Sports, about 7%. Falls, 21%. And those falls happen in older adults. It's really sad when an older adult who is already challenged functionally falls and breaks their neck and becomes a spinal cord injury patient. They have a really, really poor prognosis for survival, very, very long survival after that. Violence is another huge one, so gunshot, stabbing. Most injuries don't truly sever the cord. The cord is usually still intact. It's just been torqued, twisted, damaged, and pulled on or something that causes bleeding or tearing of axons that limit function, but you don't typically lose all function. A lot of spinal cord injuries are incomplete in nature, and that means there's some role and some ability for them to regain some improvements, and that's where, as physical therapists and really doing this very proactive, intensive therapy, where it used to be considered, hey, just put them in a wheelchair and teach them compensation. Now there's places you can go where they'll do whatever they can to regain whatever function you might have available to you before you say just stick you in a wheelchair. Let's try doing walking. Let's try doing things that your body might have the ability to do depending on the nature of your injury. Because if we just stick you in a wheelchair, there's no way you're ever going to get that back, but we can at least try with some of these things. Tetraplegia or quadriplegia is where they have involvement of all four limbs. And again, I mentioned that people can be walking like a central cord injury that maybe extends out far enough that they've got some weakness, they've got really profound weakness in their arms and a little bit of weakness in their legs, both legs, with some spasticity in their legs. They're still considered a tetraplegic because all four limbs are involved. If the lesion is below, T1 or below pretty much, that's only lower body, so that's paraplegic. So as long as you have dysfunction in your both legs, you're a paraplegic, even if you're walking around. Okay. Tetraplegia is more common than paraplegia just because the cervical spine is more vulnerable. It's more common to injure your neck and get a spinal cord injury than it is your lower body, than your trunk. Classifications of spinal cord injuries. The complete injury is a lack of sensory and motor function, including the lowest sacral segment. So complete injury, you've got motor and sensory function. So let's say I damaged my spinal cord at T10. Everything below motor and function is lost, including in my lowest sacral segment. And the only way they test that is the doctor comes in, sticks their finger up your rectum, and sees if you can feel that or if you can contract on it. And so that's the bulbocavernous reflex they're looking for, is if they stick that in there, does your rectum contract around that, and can you feel it at all? And if you can feel that finger or contract around that finger, then that means you're an incomplete. Even if you have really very little motor function, they still classify you as incomplete. So you have to have loss of all motor function, including that lowest sacral segment, to be considered complete injury. So incomplete is there's preservation of some motor and sensory function below the level of lesion. So they have maybe some sporadic motor and sensory function, but it has to also include that lowest sacral segment, that there's some motor or sensory function in that lowest sacral segment. The neurologic level is different than the injury level. So that you might have injured a certain vertebral body, C5 vertebral body burst fracture, but your actual neurologic level is defined by the level of neurologic function you have, okay? And that's defined as the most caudal, the most lower nerve root level with normal motor and sensory function. That's how you define the neurologic level of injury. And injuries can be oblique. Like, it's not always like you damage the spinal cord exactly on the left and right the same. So you can have an oblique injury, which means on this side, my level of neurologic injury might be a C7. This side, it might be a C6 because C7 is okay on this side because it's an oblique injury versus a straight across injury like this. So most commonly, they're just going to define the level of injury on both sides below the level, but occasionally you'll have one side of the body is a C6 and one side of the body is a C7 if it's an oblique injury. There's a scale called the Asia scale, an A through E classification is a system using standardized assessment and evaluation forms. So there's a standardized assessment of where you assess their motor function, their sensory function, you check these boxes, and that's how it helps you determine the completeness of the injury and the level of the neurologic injury on both left and right. Okay, and injuries are often asymmetrical, like I just said, and they need to be classified for both left and right, but also sensory and motor. So you may have a left and right level of neurologic injury different, but also a different neurological level for sensory as a C6, but motor as a C7. Because remember, there's some overlap of dermatomes, and there's just, you never know with some of these weird injuries that what's going to get past that injury, and so you can define both left and right, and then the motor and sensory levels. Okay. Most commonly, though, you eventually kind of agree on there's right about this is where most of them end, or below that level. So this is the Asia impairment scale, and if you're an Asia A, that means they're complete. They have no motor or sensory function, and that also includes the sacral segments S4 to S5. They have nothing preserved below that level, okay, including the sacral segments. Then there's incomplete with Asia B. Sensory, they have some sensory information, but not motor function is preserved below the neurological level, and includes the sacral segments S4 and S5. So they have some sensation sporadically below the level of the injury, including some sensation in that lowest, that S4 to S5, in the rectum area. Okay. C is a incomplete, a motor incomplete. So now we're starting to see some motor function is preserved below the neurological level, and more than half of the key muscle groups, which are basically your myotome groups, they're testing your major myotomes, more than half of those key muscles below the neurological level have a muscle grade less than 3. So more than half of those have a muscle grade. So they might be able to move them, but they're not moving them against gravity. They're less than 3. It's a motor incomplete level C. Then we have a D, which is incomplete motor function is preserved below the neurological level, and at least half of the key muscles or more now have a muscle grade above 3. So they can move their limb against gravity for more than half the muscle groups. of the key muscle groups. And there's a little form you fill out that has the key muscle. It tells you exactly what to test, which are the key muscles, which dermatomes to test, and you score each of these. And then you kind of then helps you determine which classification or area impairment scale. So you grade them on the, you give them a B, C, D, or E, plus you give them a neurologic level, okay, which you assign them based on where the motor and sensory levels are on this scoring sheet, okay. E is normal, motor and sensory function are normal, okay. A lot of the research that's done on spinal cord injury with like improving like walking and regaining walking ability, most of them limit their patients to, they have to be ASIA C's or D's. They have to have some motor function. They're not taking people with only sensory function or complete injuries and just putting them on treadmills and seeing improvement, okay? Doesn't mean you can't do that for some kind of general fitness or exercise and mobility, but you got to have some intact tracks to utilize to get to see the improvement in motor function. And we'll get into that when we get into the clinical neuro in the fall, and we do a whole case in a week on neuro. You're going to learn about the ASIA scale again, how to score it and all that stuff. We bring in a spinal cord specialist who comes in and talks to you guys about that. Various disorders affecting the spinal region. We've talked about, you maybe heard about some of these. So developmental disorders, spina bifida. When we talked about spina bifida, and we talked about those various levels, the spina bifida occulta, meningeocele, meningomyelocele, the various levels of where they involve more and more of the spinal cord and the tissue of the spinal cord. Something they've used to do for spastic cerebral palsy, but do less of, very little of, this dorsal rhizotomy, where you go and you cut the dorsal roots, basically ruining sensation in those areas, but also inhibiting that stretch reflex. So if they're really, really spastic, like these are kids that like the parents can't even pull their legs apart to put a diaper on them or dress them. And so you go in and you cut those dorsal roots, and that takes away the spinal cord reflex loop there, and so their spasticity drops, but they also lose some sensation. And of course, if they find some cure in the future for spina bifida or improving spinal cord function, you cut through those dorsal roots. There's no going back from that once you've damaged those. So they try not to do that, but it can be used in certain select cases. We've mentioned radiculopathies a million times. So this is a spinal root, nerve root lesion, which is called a radiculopathy. And it can be because of mechanical irritation, which is probably the most common. Trauma, like you get this avulsion injury, you're in an accident, and your neck gets laterally flexed while your arm gets depressed, and you can actually pull at and tear on nerve roots as they exit out from there. Then also, here's the mechanical irritation. Here's our disc problem here. Here's the disc protrusion. Most protrusions happen posterior lateral because we have a ligament right here. What's the name of that dang ligament? It runs right at the middle of your, is it the posterior spine? What's that? Yeah, posterior longitudinal ligament. It's pretty strong. And so when you have and there's a little thinner here in the posterior lateral part of the disc, but it tends to protrude. Your disc will migrate. This nucleus pulposus tends to migrate posterior lateral around that ligament. And so that'll migrate out and push out here towards one side or the other of your spinal cord here. There are people that do have central protrusions though, and a central protrusion can be bad, especially if it starts pushing on your spinal cord. And you'll have patients who come in, and if they have any kind of upper motor neuron signs, they come in with a big disc herniation or bulge, and you test their reflexes, and they have a hyperactive reflexes in the lower body and a Babinski reflex. Oh crap. Shouldn't be doing traction or manipulation on your neck. You need to go back to your doctor. You need surgery if you have a central protrusion that actually pushes on the spinal cord to impact those vertical tracts. But most of the time, it's going to go out posterolateral and just impact the spinal nerve root, okay, as it's exiting out the foramina there. MS can happen in the cerebrum, brainstem, spinal cord, all of the above. My brother has lesions in the cerebrum, brainstem, and spinal cord. Fortunately, the lesions are small enough and didn't impact any of the major vertical tracts, so he looks pretty good and pretty normal. But he could get a lesion, and that's why he's on medicine to provide that could impact, one of the major vertical tracts, and then he's hemiparetic or he's got some major sensory deficits. But it's more these random areas of demyelination, highly variable in presentation. A common sign that you'll see in people with MS, and this is how I've picked this up in my brother, is Laramie sign, or I don't know if it's Laramie sign or it looks like more Laramie. It's got two T's on there, so I think it's Laramie sign. It's a shock-like sensation that a patient gets. It radiates down the back or limbs with neck flexion. So it's like, ooh, you get almost like a shock, and almost like it's like somebody shocked you when you tip your head down. You're stretching the spinal cord, and you're stretching the dura, but you're stretching actually some of the axons in there a little bit. And when you have that demyelination that's occurring because of the oligodendrocytes breaking down, during that initial process, because you get a little leaky there and a little crosstalk, and when you stretch those little areas of demyelination, it creates a little sensation and can create a little action potential there and create this shock-like feeling when you have those little areas of demyelination being stretched. And my brother was complaining that when he was sent for a couple things. When he was running, he said he had a little bit of trouble feeling or sensing where his leg was landing on the ground. So that's sensory little loss there, proprioceptive loss possibly. So it could be a little lesion back in the dorsal columns. But then he said what he would do is he'd try to look down at his foot to see where it was landing. So he's doing neck flexion with kind of almost like a straight leg raise. His leg out in front of him, he'd get a little shock sensation occasionally when he was trying to look down to see where his foot was located. So I'm like, yeah, that's not an orthopedic problem. That's a neurologic problem. And his actually symptoms all started with shoulder pain and some weakness in his shoulders that he was treated for like 2 years for orthopedic rotator cuff kind of things. But his pain was not being elicited by mechanical stimulation. He'd have shoulder pain, but he would not have. I'd ask him about any specific positions that cause it to have pain or anything like that, and he couldn't really define anything. So the lack of mechanical dysfunction plus those other things, that's what he finally said, get an MRI, dude, and see what's up in there. So, but he probably went 3 years or 4 years till he got on the medicines, which could have been a problem if he had a major, flare-up. Compression of the spinal region, anything that puts pressure inside the spinal region can be a problem. Any kind of tumor that takes up space, you only got a limited amount of space in there. Cervical spondylosis, that's where you get narrowing of the central canal. You get neck and upper extremity pain. You can be the central canal or the foramina. So cervical spondylosis, where you get these osteophytes and these little protrusions around the foramina or around the lips or edges of the vertebral bodies, and they can impose on the spinal cord or the nerve roots coming off. Neck and upper extremity pain, sensory motor deficits, hypertonia in lower extremities. You can get a Babinski sign. This is where you get this narrowing, where it actually starts to compress those vertical tracts. They're not totally damaged. We start compressing those vertical tracts and eventually start exhibiting some of these upper motor neuron signs. Syringomyelia, I mentioned already. That's that very unique syrinx filled with fluid cavity. It tends to happen between the ages of 35 and 45. It's almost always in the cervical spine, typically in the C4 to C8 region. Gives you the same symptoms as central cord syndrome as it expands. This is some of the osteophytes we're seeing here, cervical spondylosis, where you have the edges here. But these osteophytes can protrude posteriorly all the way into the spinal cord region here, which can lead to, these osteophytes can lead to spinal stenosis. That's what stenosis is any narrowing, okay? We can have canal stenosis from the spondylosis that they protrude into the actual canal, spinal canal, or they protrude into the foramen where the spinal nerves are coming out of. So this is trying to show you some little osteophytes forming, and this is showing you osteophytes here and little osteophytes protruding and impacting on that spinal canal. And this is getting even worse here. This is really showing some narrowing of the spinal canal because of osteophytes compressing there. And then here's a lateral foraminal stenosis right here, where you get the osteophytes protruding into the foramen. And they may have both. Some patients may have both, central and foraminal stenosis. That's just typical with arthritic degeneration in the spinal region. Some people are just more prone to it genetically. And that's that too, showing you some of those osteophytes. You guys have class right now? 10? Okay, I better let you go, Dr. Fillmore. I forgot to tell you, Crystal is coming in.